what I was talking about is how to differentiate the three things we have three things to differentiate between. First, the ectopic, either it is cervical or cesarean scar, and the cervical abortion or miscarriage. Miscarriage, this means that this pregnancy is not attached here, it's just failing. So you will find the sliding sign positive. This is the first one to differentiate. The second, the two others, they both have a sliding sign negative, but one of them is above the internal os and the second is below the internal os. The cesarean scar is above the internal os, while the cervical is below the internal os. Okay? The second point in this question is how...
Yeah, her beta HCG is also rising.
Yeah, and yeah, this is another thing, but I'm saying just by ultrasound how to differentiate. And now this one, we already said that this is cervical ectopic. What is the best treatment for cervical ectopic? How to
systemic ultrasound or injection by methotrexate.
Local injection.
Not
yeah.
surgical.
Can need to hysterectomy.
Okay. The best method to treat cervical ectopic is methotrexate.
Local injection by transvaginal, صح?
No,
right?
Systemic.
You can do both systemic and local, but the most efficient is the systemic. Okay.
Most efficient. Okay.
Is the systemic, especially there is no fetal heart. If there is fetal heart, go first for feticide, then do the systemic. Why? Because you are afraid to go for surgical. Surgical here, you are putting yourself in a very horrible situation. She will bleed till she die. The problem here is the bleeding. Okay? This is the point why we are not preferring surgical in cervical ectopic, because cervical ectopic, if we went for surgery, this is horrible for us. You will be in a very... this may lead to hysterectomy. Okay, so this is this question. Let's go to the next. Miscarriage.
Please, can we see the answer? I can see it.
Okay, I will show. The options here, we said that we are going for
methotrexate,
yeah, intramuscular, and this is the explanation. The clinical history points towards cervical ectopic. Systemic methotrexate is currently found to be more useful. 91% of patients will be cured by this. Okay, so let's go. Let's go for next. The next one is management of miscarriage.
Question number 1, 24-year-old woman present with moderate vaginal bleeding with crampy abdominal pain at 6-week gestation. Her urine pregnancy test was positive 10 days ago. Speculum examination to a partially open cervix. Transvaginal ultrasound shows an open internal os with mixed echoes. Within the cervical canal, there is a small gestational sac with yolk sac and sliding sign is positive.
Okay.
The incomplete.
Moderate vaginal bleeding. Wait. This is a moderate bleeding. The cervix is open. And you have mixed echoes in the cervical canal. This means
Mhm.
blood.
Mm.
Gestational sac, yolk sac, and sliding sign positive. Sliding sign positive means that this is abortion. This is inevitable abortion. Inevitable abortion. What will you do?
Waiting. Wait and see.
No, wait and see. Expectant.
Can you differentiate it from incomplete miscarriage, please?
The sac is still inside.
Internal os is open, no?
Yeah, but the sac, no, she is, look, incomplete means is that she already had the miscarriage, but still some remnants are there.
Some
Okay?
products should be passed already.
Yeah, some products will, but this one, the sac is still inside, and the os is just partially open. So it is inevitable abortion.
Okay.
Not-
For treatment for both incomplete and inevitable is the same.
Yeah,
Supposed to be
you
in- if-
incomplete if the os is open. Incomplete,
our
you will see.
discussion
If the
is-
os,
Our discussion is what to do for what. If it is if it is inevitable abortion, if it is going to be abortion only, then we do expectant. But when it is
Yeah.
incomplete abortion, we have to see how is the
according,
patient hemodynamically. If she's bleeding excessively, then you have to complete the procedure. Maybe you will have to, expedite
Yeah.
the procedure. If it is not bleeding heavily, then you can wait for the spontaneous expulsion.
exactly.
Okay.
Okay.
Can we see the answer, please? Management as it is inevitable abortion.
Yeah, this is inevitable. Expectant management of the situation is advisable if the bleeding is not heavy and the clinical findings are suggestive of miscarriage. Conservative management may be followed. The presence of yolk sac confirms the intrauterine pregnancy, and the sliding sign exclude a cervical ectopic. Okay,
Okay.
so let's go for the next.
37-year-old woman returned to her for her review to the early pregnancy unit. She was noted to have an incomplete miscarriage for a week ago. Her bleeding has gradually tailed off over the week. On examination, it was found that the os is closed and there is no vaginal bleeding. Incomplete
Okay.
miscarriage ago. Her bleeding tailed off.
Now she became, you are suspecting that now she has complete miscarriage. What to do after complete miscarriage? How to follow up?
Pregnancy test after
Just
3
confirm.
weeks from the miscarriage.
Home pregnancy test.
UPT
Home
is,
pregnancy test. Okay.
Yeah, which
Do pregnancy
So-
test after 3 weeks.
Okay.
Urine
Yeah.
beta HCG after 3 weeks.
yeah, okay. Okay.
yes.
تمام. Okay. Urine beta HCG after 3 weeks. Okay.
Which suspected. Someone is just sharing some stuff. Okay. Let's go for the next.
Okay. 37-year-old لا number 3
Yeah.
or what?
Yeah, number
طيب,
3, sorry.
slide
Yeah.
34-year-old woman present to the GB with spotting at 9-week gestation. She is referred to the early pregnancy unit where she is found to have a missed miscarriage.
Yeah.
Spotting 9-week gestation, 9 weeks spotting referred to early, which
Missed miscarriage. What is the management?
Missed miscarriage. What is the management?
ميفوبروستون مع ميزوبروستول.
What is the dose?
هي
100.
200 mifepristone and 800 misoprostone microgram.
أنا عارفة 200 ميفوبروستون اللي هو ملي جرام بلس الميزوبروستول بقى حسب الجستيشنال ايج ده 9
No.
Only misoprostol.
No. Not according to gestational age. Here we are giving one dose.
8
800 microgram.
800 means
800 for
800.
mid and 600 for incomplete.
But it's supposed to be like this: 600 for incomplete and 800 for missed. But we can give both 800.
Okay.
Yes.
800 can
So-
be given to both.
Yeah.
Answer is D, huh?
Yeah, the answer is
You
what?
said for incomplete we give 600.
Yeah. We are supposed to give her the incomplete. We are supposed to give her 600, but
Okay.
in order to make it easier for us, the
Mm.
Royal College bought one dose, only one dose, 800 for anyone, for
Okay.
both. But I'm telling you, this question you need to be careful. He is putting 800 in the 800 in the explanation, but he is putting the key wrong. This key is supposed to be D, not C.
D.
Yeah, the key, he is putting the explanation right, but the key is wrong. So keep your
Printing
eyes
mistake.
closed.
Maybe printing mistake.
Yeah, keep your eyes open for this.
Okay.
So it is 800. Okay, the next.
You are reviewing the histology results for your consultant, Mrs. X, 32-year-old with a missed miscarriage and empty gestational sac, ought to have a suction evacuation. Histology of the product shows a decidual reaction with absence of chorionic villi.
Yeah.
دي حاجة
she could be an ectopic.
No, this is can be ectopic. Decidual reaction means that the
Empty gestational sac, and there was never an intrauterine pregnancy because
yeah,
there is
there
no
was no
chorionic villi.
yeah,
So
there is
it
So
no
you
is
have to
ectopic,
look
huh?
for ectopic.
yeah,
So
so
for
you
that,
will
beta
you will
HCG.
yeah, beta HCG, but which one? Urine or serum?
serum.
Serum beta HCG.
Yeah, because this is more sensitive.
And based on serum beta HCG level, if it is more than 1000, you should see a sac. If it's less, then you will have to wait.
Okay.
There will be pregnancy of unknown origin,
Yeah,
unknown location, PUL.
BUL. Serum beta HCG will ensure that this is not an ectopic or pregnancy of unknown location with pseudogestational sac. Okay, next question. Management of ovarian cysts. Very,
جالنا.
very important. Look, I'm telling you, if I'm telling you that we got 20 questions from this, I'm not lying. Last exam, he was just like, I don't know, maybe he had a case of ovarian cyst or something. He was flooding us with question about ovarian cyst. Before, let's revise also an important chart. we are I'm
So
trying.
that we are able to answer the question, huh?
Yeah, is this good?
Yes, this is good.
Strategy good?
Yes.
It refresh our knowledge plus what is
Let us read it, please.
let's
As I hate it.
cyst. Yeah, perimenopausal. Yeah, which one? Postmenopausal, I think, is the one having the
Is this very menopausal also, sir?
yeah, but
Ovarian mass.
yeah.
I think.
No, one of them have a chart. That's what I'm looking for. Which
Yes.
one of them? Yeah, this one.
Postmenopausal cyst, 1
Postmenopause.
centimeter or more.
Yeah.
Okay. Can I
So
read?
both-
May I explain it?
Yeah, anyone
Okay.
who
Okay.
Who raised
Post
their
menopause.
hand?
I am Dr. Ghazala.
Yeah, you are the one who raised your hand?
Yes. No, not raise hand. I'm just
No,
asking
someone
verbally.
raised your hand, please. Why you raised your hand? Tell me.
I don't know who has.
Type in the chat if you have a question or something. Okay. So I just wanted to know if they have a question or something. Okay, you can.
Okay, dear. Okay, I will continue. Postmenopausal ovarian cyst, cystic lesion 1 centimeter or more. After that, we have to measure CA 125, TVS, and ultrasound.
Plus or minus
Ultrasound.
transabdominal.
Yes. This we do to calculate the RMI. Okay. After calculating the RMI, we get two scenario. If it is less than 200 or if it is more than 200. Okay. If it is more than 200, it means it is high risk of malignancy. And what will we do? Usually the question comes CT scan, abdomen and pelvis, if it is more than 200.
Yeah.
After that, you have to refer for gynecological, oncology, MDT review. There, what will happen? MDT review, if there is high likelihood of ovarian malignancy, we will do the laparotomy and full staging procedure by trained gynecological oncologist. This is the difference. If it is high likelihood of ovarian malignancy, the oncologist gynecological will treat. But if it is low likelihood of ovarian malignancy, then we will also do the laparotomy. We will do the THBUSO plus omentectomy, peritoneal cytology, but it will be done by routine general gynecologist.
Okay.
Okay. Then now come to the scenario if the RMI is less than 200. If it comes less than 200, you should keep it in mind. No problem. This is low risk of malignancy. Okay. And here we should keep it in mind that if cyst with any of the following features, yani ke if there is symptom, patient has pain, if non-simple features greater than 5 centimeter or multilocular or bilateral, what should we do? We should do the BSO. Okay, we should do the surgery, salpingo-oophorectomy, bilateral. But if the cyst fulfilling all the following criteria, asymptomatic, patient has no symptom, just we see on ultrasound less than 5 centimeter, unilocular, unilateral, then we will consider the conservative management. And we will repeat it again after 4 to 6 months, same. We will do the CA125 TVS or plus minus TS. Then after that, we have 3 scenario that either it will resolve after 6 months, we will see the cyst is resolved and we will discharge the patient. But if the cyst is remains same, yani we saw it was 5 centimeter, now still it is 5 centimeter. So we will repeat it again after 4 to 6 months. We will assess it and then we individualize the treatment after discussion with the woman. But if this cyst after 6 months, when you did CA125 and ultrasound, there is change in the feature. Yani it is 6 centimeter, it become some other changes came in this. So we need intervention.
Yeah, okay. And another important point is how to calculate the RMI. RMI is
yes,
calculated.
this is
something in the chart. We in the up in the chart. Yes, consider salpingo-oophorectomy, usually bilateral. If you read this,
we read it. We read it.
we read it.
Yeah.
Okay.
Yes.
Okay.
RMI just 3 things: ultrasound and this CA125 and age of the patient. Yani ke if patient is
Menopausal status, if she is pre-menopause or post-menopause.
yeah, For premenopausal 1 and for postmenopausal, you have to give the number 3. CA 125, whatever the unit comes, you have to write the that one. But for ultrasound, if there is no feature, 0. If there is one feature, 1. But if more than one feature, yani ke, cyst is bilateral and also it is multilocular, then you will give 3 points.
What we are looking for in ultrasound is multilocularity, solid areas, metastasis, ascites, or bilaterality. If any one of these, only one, you will give a score 1. If 2 or more, you will give a score 3. Okay, so this one we get very quickly, because this is the key to answer almost everything. The mass, perimenopausal mass, it doesn't have. I don't remember it having any shorts, right? Yeah, perimenopausal ovarian mass. Let's see. I don't remember it having any charts. This is what? Yes, this is what types of adnexal masses. As I told you, it doesn't have any charts, so I remember correctly. Okay, so.
Okay. Question number 1. 26-year-old woman present to the gynecology outpatient department with an ultrasound scan of her pelvis for menorrhagia. It report an echoic ovarian cyst, 28 milli, 37 milli on the right side. No other abnormal finding are reported.
So.
No other. At 26 year.
This one is less than 5 centimeters.
Mostly it should be a physiological, because she is young patient, 26,
and
anechoic.
less than 5 and less than 5 centimeters. The cut value for premenopausal is 5 centimeters.
Yes.
If it is less than 5 centimeters with no solid masses, like uniechoic, no nothing in
just it. Reassurance, yes.
Yeah,
conservative, just expectant,
Yeah, and it will go within 3 cycles.
3 cycles, 3 menstrual cycles,
without any intervention.
Okay.
So just reassurance,
Yeah, so let's see.
If it is 5 centimeter, I think then we will advise ultrasound after 1 year.
5 centimeter, I think.
Yes.
Yeah, we have to repeat it. But
I can't chart. I will.
No, but if it also depends upon whether it's a young patient, even if it's 5 centimeters anechoic, and if it's a young patient, you can wait. Only if it's persistent. Only if it's persistent.
Actually, there is one chart here that if it is less than 5 centimeter, yani suppose it is 4 centimeter or 3 centimeter, it is physiological. It will resolve within 2 to 3 months. Okay, no follow-up is needed. But if it is between 5 to 7 centimeter, then it is written yearly ultrasound. Yearly ultrasound, dear. Yearly ultrasound after every year. But if it is more than 7 centimeter, then you need MRI or surgical intervention.
Yeah, this is I will show it to you. Okay.
Yes.
This is not in the guideline. This is the TOG article.
Yes.
For the pregnancy. Yeah. Okay. That's why I told you. I know that the guideline don't have a chart. Okay. This is the other chart. I will also be it is a group. Adnexal masses on at ultrasound. It is either asymptomatic or acute abdomen. Acute abdomen, so we will go for surgery.
Yeah.
Asymptomatic, it is either benign, suspicious malignancy, or intermediate. If it is benign, simple, less than 5 centimeters, no further action.
Okay.
If it's simple, more than 5 centimeter or complex, you will go for a rescan 4 to 6 weeks. After 4 to 6 weeks. If resolution of the mass, okay, no further action, no change in the size, we will rescan 6 weeks postnatally or 6 weeks after it. Okay.
Actually, this logarithm is adnexal mass in pregnancy.
In pregnancy, that's what I'm telling. This is the talk article
Yeah.
for pregnancy. This is what I'm telling.
Yes.
Intermediate.
This is.
Yeah, intermediate or suspicious MRI, MRI and tumor markers, especially LDH. For young patient, we will go for LDH. If high suspicious, we will go to surgery. Low suspicion, we will rescan. I'm going. I think there is something else. I'm with you, but it is not a chart. It is like you collect it from the guideline. Yeah, this one. Yeah. Okay. Yeah. It's very small, and let me try to yeah, zoom in. Okay, now you can see it, right? Okay. Premenopausal asymptomatic simple cyst. If it is less than 5 centimeters, this is functional, no further action. Okay. If it is 5 to 7 centimeters, we will follow up after 4 months. Resolution, no further action. Enlargement, we will like have another opinion, see why. And 7, but this is not what is in the guideline. No, there is something else. Let me just get my notes. Mess. Okay. Which one is with my notes?
And you search for what يا دكتور أميرة؟
No, I'm searching for my notes.
اوكي على ovarian mass يعني size بتاع البريمينوبوزال.
Yeah. This one of them.
ده GTG.
Yeah, I know. It is a GTG. Yeah, this one is containing my notes. Okay. Let me just check it. Okay, functional or simple ovarian cyst. This is less than 5 mm. It resolves within 2 to 3 menstrual cycles. This is as we said. Okay. And the other one, just no, not here. Okay. Yeah, this is the one. Yes, Dr. Ghazala, this is the one you are looking for. Women with a small or less than 50 mm diameter, less than 5 centimeter, simple ovarian cysts don't require follow-up, as these cysts are very likely to be physiological and almost always resolve within 3 menstrual cycles. Women with simple cysts 5 to 7 should have yearly ultrasound follow-up. With larger and those with larger simple cysts should be considered for either further imaging, MRI, or surgical intervention. This is the point Dr. Ghazala is looking for.
Yes. Yeah. I send it in your WhatsApp group.
Yeah, I'm also going to do the same, because this one I really at this point I even highlighted it. That's why I was looking for my notes, because I know that I highlighted it. Yeah, I know that I highlighted this point. Okay. So we almost said everything.
Yeah.
Okay, so this one, she is nothing. We will just go for expectant management in this patient because she already have simple cyst less than 5 centimeters. Second question.
54-year-old woman present with abdominal pain and had an ultrasound scan done. It showed an ovarian cyst which triggered a transvaginal scan. Pain has resolved now. A 46 millimeter cyst with a thin wall with normal CA at 125 is noted. She has a repeat scan after 2 months that shows 58 millimeter cyst with similar features and normal tumor markers. No new symptoms are noted. طيب هي
So this
54
one
ده
is
4-3 وصح والمفروض ان هي
no, no,
دلوقتي
no.
5
Yeah. Okay. Go.
نورمال سي ايه يبقى ماشي اوكي هو دلوقتي هو مش بيقل نورمال هو كان 46 ملم
It's
وافتر
increasing.
بعد في
It's
They
increasing
haven't told
58
whether she is a postmenopausal or a premenopausal, but we'll
No,
assume
it
that
is
54.
understood. She's 54.
54, she'll be postmenopausal.
Yeah.
And
Yes.
then we have to
But,
see the scores. Yeah.
Score you, how can you take C125? They show just normal, not mentioned.
This one, he is
Then-
directing you that this is a normal, this is a cyst that needs follow up, nothing more. But now after follow up,
I think 4 to 6 months.
we
we
already
can-
did. Yeah,
She had
no,
done
for-
a repeat scan, no, after 2 months. But again,
Yeah,
it is a persistent with similar features. But the tumor
So-
markers are normal. So should we go for a yearly scan then?
Yeah, no. Now you have not now the size is increased. This is
Yes,
deteriorating.
58 millimeter now. Before
The
46.
size, the size is so this is progressive, not regressive, not stable.
Yeah.
So for
with
this
similar
patient,
feature.
Bilateral salpingectomy, ovarian cystectomy.
yeah, for
Bilateral,
me,
yeah.
I will go for this. For me, I will go for bilateral salpingectomy.
Removal of ovary.
But why you want to keep the uterus? Why not you do THBSO? And
Look here, he is
No, in UK,
giving
you cannot do something without evidence.
Yeah,
So why to remove her uterus? Yeah.
unless she requested this. If she requested to
Yeah.
remove the uterus with the cell, the ovaries, okay. Other than this, the recommended operation is bilateral salpingo-oophorectomy according to the flow chart.
So
That is
what-
over treating. No, you removing the uterus is over treating.
Yeah.
يبقى
so what you will select H, laparoscopic
me-
removal of ovary?
For me, I will do this, but I'm not with the key. The key is going for G.
Yeah, laparoscopic removal of cyst.
But
No,
we
no,
don't
no,
do
no.
cystectomy. We don't do cystectomy.
Yes.
We do
At this stage of
this.
no.
Yeah.
Yes.
Should be H.
Yeah, for us, we will go for H according to the guideline.
Yes.
The guideline, you do BISU. Bilateral
Here
salpingo-oophorectomy.
he tell one ovary.
What?
He tell one ovary.
One ovary, why? What? Even if the cyst is in one ovary.
He tell removal of the ovary. هنا unilateral cyst.
Look.
No, maybe
No.
because it doesn't have any.
what is the answer please what is the answer
I will let me once.
Because it
answer-
doesn't have any suspicious features. Only there is an increase in size. The increase in size could be because of intracystic hemorrhage or any this thing. Because its tumor markers are normal and everything. So probably it's only going for the ovarian cystectomy.
Look, this
yeah
question is
bilateral
very-
salpingo-oophorectomy كانت في الشارت كده مش دي اللي كانت
This one
أيوة.
is here. It is not fulfilling the criteria. It is less than it was less than 5 centimeters. Okay, and we did 2 months repeated scans. So we did this one. This point we did. Now it is a change in the feature. It became larger. So according to this, we should consider intervention. And the intervention here,
Surgery. Yeah, but what
surgery.
to
Wait,
remove?
but which one? Okay, let's
Yeah, why to
do-
keep the other ovary also? Yeah.
let's do it. Let's go. Okay, let me get the one that is with my notes as well. Yeah. I'm sorry, because the one with my notes is very, for me, it is easier to identify the points. Okay. Okay. So, managing, no management, we will go for management.
And you search for what, Dr. Amira?
We are searching
For what?
management. Yeah, this is the management of the management options. Okay.
Should we see it on the top?
Asymptomatic.
Okay.
Look here, asymptomatic, simple, unilateral, unilocular ovarian cyst, less than 5 centimeter diameter, have low risk in malignancy. In the presence of normal serum CA 125, these cysts can be managed conservatively with repeated evaluation in 4 to 6 months. If it is reasonable to discharge after 1 year if the cyst remain unchanged. Okay. So needs,
we
so
follow up.
Surgical
1 year.
evaluation is
If
necessary.
unchanged, we follow up
here
for
a
1
woman,
year.
wait,
Unchanged.
Dr. Iman, please. A woman with suspicious or persistent complex needs surgical evaluation, and he referred us to section 612. Okay. Aspiration is not recommended. This is something we should know, that aspiration is not recommended. Okay. Laparoscopically ovarian, women with RMI less than 200 suitable for laparoscopic management. Okay. Laparoscopic management of ovarian cyst in post should be undertaken. Okay.
No, 6.12.
Bilateral.
This is the second point. Which is the first point? 6.12. The first point.
This one is just
is about
the
aspiration.
Of,
okay, fine.
The second
so
point
that's not
is,
recommended. Second is laparoscopic management.
Okay.
First is aspiration. It is for surgically unfit. Now is laparoscopy.
Laparoscopy. We will do laparoscopic management of ovarian cysts in postmenopausal women should comprise bilateral salpingo-oophorectomy rather than cystectomy.
This is our answer.
Yeah, this is stated clearly. Bilateral salpingo-oophorectomy.
Yes. I asked about اللي هو yearly